the drop-off is near the registration area. And if you also want to review your presentation, please do so tomorrow early before 10 a.m. Thank you.
Assalamu alaikum. We start this evening a topic called One Health, employing One Health as a field epidemiology approach, and it's called round table discussion. It means that all parties should contribute and give, as we go in discussion or few slides or few ideas, we need your input please as we go on, and not simply just giving a talk and everybody listens. That's what's meant by a round table. And myself, I am Jamal Wadi, infectious disease from Jordan.
My name is Elizabeth Hatting. I'm actually based at the American Embassy here in Amman, and I cover the Middle East and North Africa for health issues.
And good evening, everyone. I'm Erin Sorrell, and I'm from George Washington University School of Public Health.
Great. Well, good afternoon, and thank you very much. I'm really pleased to be here and really grateful to EMPHNET for putting on this great conference. They've been a terrific partner for a few of our State Department programs, and so I congratulate EMPHNET on the great work and all of the outstanding presentations today. I know I've learned a lot. I will preface my remarks by making the point that I'm actually a Foreign Service officer, and so I cover actually environment, science, technology, and health issues for this region, but I'm not an epidemiologist or a scientist necessarily. I have a background in these fields, but I come from also an economics and business background, and so One Health is a great opportunity to kind of look at the bigger picture and how these issues fit together, because I think when you think about the nexus of human health, animal health, environment, all of these things become very stark. And when we approach these issues as policymakers, we're often looking at, what are ultimately the implications. And so that's what I will talk about a little bit today, and the importance of, sort of the field epidemiological approach in this context. And then my colleagues will, go into a little bit more detail on the technical aspects. So again, I really appreciate the opportunity to talk with you. I think one of the things that we continually have to remind ourselves as we look at all of this great information, all of the great studies, is why is health so important? And from the perspective of someone who looks at economic issues, political issues, these are the foundations of an economy or a society. You can't have a healthy economy or a healthy society if you have an unwell population, and all of these different issues. And so I know that sometimes it's a challenge to get sort of higher level decision makers always focused on these issues, but it's really beneficial to consider. And as I travel in the region and talk with host governments, one of the things that really comes up frequently is now, of course, you have all these re-emerging vaccine preventable diseases, while at the same time you have developed economy problems like the rise of NCDs, and these challenges interact. If you have an unwell population in terms of obesity and diabetes, what are the implications when you have emerging vaccine preventable diseases or something like MERS? The one issue too that frequently recurs is that and the region I cover is a little bit different from the EMER region. I'll just qualify that so that it also includes parts of North Africa and elsewhere. But there is the interaction between ministries of agriculture and ministries of health in particular should be strengthened. And this is where the One Health approach is extremely important, as it fosters that collaboration in laboratories, in the field, elsewhere, these two bodies should always be talking to each other and thinking about what are they seeing, what's emerging, what are the risks. And that's a lot of what we do when we're out in the field, so to speak, out posted abroad and looking at these issues and working with all of our colleagues in the technical agencies. So we have a lot of our CDC experts here. We work with our National Institutes of Health, our U.S. Department of Agriculture. All of us work together all the time, and even when we're out at embassies, it's like a microcosm of Washington, and all of our agencies, whether Department of Defense, State Department that I work for, like I said, Department of Agriculture, we're constantly communicating with each other and looking at what is happening. And so, just to give you sort of an anecdote of what this looks like when things are actually fast moving in an outbreak is when I was working in Asia in 2009 and, we had the H1N1 outbreak. Suddenly, you think you have a lot of information, but all of a sudden they're, quarantining people forcibly or asking people to stay at home. People don't know what to do at, the ports, the airports. I mean, all of you know this very, very well. But this underlines the importance of good data, because when you're having to make decisions about what to do with people in the moment, you need good information. What we always want is that from a policy perspective, what we put in place is well grounded in science and facts. And this is true for trade as well. So when we talk about things like, phytosanitary measures, that these should all be grounded in good science. And so this is very important. So all the information that is presented and the purpose of One Health and getting people out into the field and gathering reliable information is extremely important. I think one of the other important elements of when you look at all of these factors and sort of recent outbreaks too is the incredible cost they can impose on economies. So how important it is to get out in the field and catch things early and deal with an animal health issue early is extremely important, both in terms of the immediate economic impact. So for example, you have obviously the challenge of culling animals and deciding which populations of animals to cull. This is a hard decision, and in some cases, in some economies in the region, there's concern that people may be underreporting, because if you're a farmer with a small holding and you don't have a large, poultry population, what encouragement do you have to report that you have potentially avian influenza in your flock? So this is, again, why surveillance and being proactive and getting out in the field is really important. And so, that's sort of a question that I throw out to the group to think about, what are the incentives to report? What is the encouragement that can be, given to ministries of agriculture and others to sort of work with universities, work with researchers to get out and gather as much information as possible, so you're not necessarily relying on people to come forward proactively. The other thing I would point out is, the cost of then dealing with a major outbreak. This not obviously imposes a huge loss if you have to, destroy a large, flock or cattle or something else, but you're also maybe treating and vaccinating and doing other things. If it's a human health outbreak, obviously people are going to the hospital. That means they're taking money away from, they would spend their money elsewhere. So there's a lot of losses that happen in the economy. And you look at something like Ebola, I'm sure this is all familiar, is, a 2-year Ebola outbreak could cost like $32 billion, according to some estimations. There's, the commodity price hikes that can happen, other factors. So these are, again, and it's very important to get out and understand, the scope of a problem early and quickly and be able to communicate among different ministries and actors very readily. In terms of, the issues that I hear about most frequently, when I travel in, say, the Gulf or North Africa, and many people have already touched on all of these today, things like leishmaniasis, obviously MERS, you have avian influenza, brucellosis. These are all the things that are most concerning in North Africa. There's still concern about rabies and interest in working on, collaboration across North African countries on rabies eradication. But also there are emerging issues that I would also, pose as sort of a question for, or an issue for comment is, antimicrobial resistance, and, what is that aspect of, sort of the agriculture sector, how is that interplaying with some of these issues that we see in the human health side? So all of these are the issues that we're continually looking at, and I think, again, if the majority of human health issues and diseases emerge from the animal populations, you can't look at these as separate or apart. And we do our best in all of our work to try to forge some collaboration. So, as I know our CDC colleagues highlighted the Global Health Security Agenda, I mean, that has been a, centerpiece program that the White House launched last year. It has 11 different action packages. If you look at all the different features of the action packages, many of them are focused on biosurveillance, workforce development, biosecurity, biosafety, all of these different sort of general categories that are not limited to the human health or animal health side. And so wherever we can, and we do activities, and CDC, say, comes to Jordan or goes elsewhere in the region, or we have NIH colleagues coming out, we encourage them as much as possible to interact with the veterinary population as much as, the ministries of health and sort of the human health side. The same for any of our civilian versus military colleagues. I know there was the Royal Medical Service represented. That's also very important. So the more cross-sectoral approach you can take, the better. I think, I'll just close by saying, from a policy perspective, how important the work that you do actually is to people like me, who I can tell you in a, like I said, in sort of a fast-moving outbreak, the first thing you need is good information. And, that's one of the hardest things to come by is, there's the reliable, good information has to move as quickly as the actual disease that you're trying to control. And so, I applaud all the work that's been presented. I, look forward to hearing from our colleagues who'll talk more about the technical elements. But just to highlight, how useful and the application of what you're doing is so critical. So I'll just close with that, and I look forward to the conversation, and hopefully we'll have some questions. Thank you.
Dr. Sorrell?
Okay, I apologize. I don't think my slides are up, but that's not a problem. So actually, before we began our talk today, we thought it would be interesting, and Dr. Wadi had mentioned this would be an interactive forum. So just want to get an idea. If you could raise your hand if you are a veterinarian. Okay, so we have two in the room. And I think that's a great example of the importance of intersecting both veterinary services, human health services, and the idea of a One Health approach. And so there have been many studies looking at the importance of One Health, and that One Health expands way beyond just zoonotic diseases. And as Elizabeth mentioned, there are impacts not only to the infectious diseases that we are concerned about from a veterinary and a human health perspective, but also those that impact food safety, trade, import and export, as well as environmental changes. And so when we really think about One Health, there are many, many factors to consider. Emergence and spread of new pathogens is one of today's highest global health threats, as well as veterinary threats. And I think zoonotic diseases are easily the biggest contributor to our emerging infectious disease threats. And as I mentioned, risks include both international travel and trade, the interaction of people and animals, and the intersection of shared spaces, agricultural land changes, microbial evolution, adaptation. We have pathogens themselves and how they're evolving, as well as livestock management practices. One of the things that was a topic for this roundtable was really looking at how to prioritize zoonotic diseases. I think coming from both the human health and the veterinary health perspective, it can be very, very different depending on, from a veterinary perspective, interventions for vaccines and treatments, thinking about livestock impact for management, not only for livestock, but for food safety and food production. And from the Ministry of Health, as Elizabeth noted, we have this dual burden of disease, the balance of communicable with non-communicable diseases, and really thinking about how to prioritize diseases that can cross both health and veterinary sectors. There is definitely a need for multidisciplinary teams in response in terms of collaboration and coordination, and it's integrated workforce that's really going to be the key to that. I think one of the things, the major changes that need to take place is changing from treating causes of a disease and really looking at preventing the diseases and focusing efforts on prevention. Not using humans as sentinels for zoonotic diseases, but really looking at the veterinary sector, the population, determine what those clinical symptoms are and detect at that level. And really that is reliant on that communication coordination from the rapid response teams, from the field deployable teams, from the veterinary sector, and from the human health sector. There have been some fantastic examples of One Health efforts from FETP programs, both in this region as well as in Southeast Asia and in Africa, Sub-Saharan Africa particularly. And so happy to discuss those later, but wanted to kind of wrap up with that introduction and hand over to Dr. Wadi to further discuss the importance of the integrated approach in One Health in disease surveillance and detection. Thank you.
What I'm going to do now, unfortunately, is not real roundtable discussion, but we have to go to roundtable discussion. What I'm going to do now, using this theme, employing One Health as a field immunology approach, for everybody to give us ideas or to exchange ideas about this. But just give me a few slides, so as these are the assignment that was sent by EMPHNET for us, and just looking at this slide, not just to remember but just to know the names of a lot of outbreaks that you are familiar with, whether it's bacteriology or virology, and the interaction of those illnesses between the human environment and animals and so on. So because each one of them, of those diseases, even I forgot here also anthrax, to put it on board a few years ago, that was a threat worldwide. Those illnesses, they interact between the three, the triad of that I mentioned to the far left. However, so it is not unique to humans or to animals. From this meeting, just I picked up from your presentations, who are presented per track, giving some ideas about environment, for example, water. Some studies they were done about diarrheas, about cholera, about other entities. Food safety and food is of concern. One of the slide, just I put it as an example. I'm sure there are more than one, but however, I put one of them about food safety causing gastroenteritis, and of course hygiene in relation to the environment. And let us be down to the earth in our way of discussion and thinking, is that we are discussing a part of the world which is underprivileged with limited resources. So if you see the last slide here under hygiene by Mr. Akbar, Dr. Akbar and his group, even in their recommendation, look at that slide, developing toilets away from drinking water sources or sources were advocated. In some parts of the world, even this simple thinking, they may lack it, or in different countries because of poverty, of lack of hygiene, lack of education. So you find sewage pipes and water pipes are in extreme proximity to each other, and they can mix and cause illnesses. That's our interaction. Now, in animal husbandry, again, is part of the story, whether you are using antimicrobials in other animals, human contact with animals, or animal products, again, they may interact to cause disease. Just lessons, putting MERS corona here as an example for field epidemiology. The previous slide, honestly, I just give them a shot for field epidemiology, as one of my colleague Wael mentioned while discussing another topic. He said something very virtual. He is right. Sometimes things are virtual, but if you want to make them actual, you have to bring elements in real life to use them to reach your goal. Here, if we keep on talking about theory without applying them to the epidemiologist in the field and let him know, educate him about the interaction between several elements in his investigation, he may miss point or make a mixture of points, and he may not come with a real conclusion or an accurate conclusion about his study or his thinking or his understanding of things. Here, MERS corona, I got, though in Jordan, just I finished 5 cases of my own, in Saudi Arabia, hundreds of cases, but I used this case published recently in the Journal of Infectious Disease in Developed Countries from South Korea. And the reason I did that, because it was a pure single case that moved from Saudi Arabia to, you can see here the countries, Saudi Arabia, Emirates, and other country, and Bahrain, and he moved back to Korea. One person who get a new disease that never was present in Korea, and then it progressed to infect others. I'm not going to go to the map or the program, but here it seems there was failure initially of the system to identify one thing, the illness, which looked like upper respiratory. Second thing, physicians in the ERs, nurses, healthcare workers, I'm not sure whether there was also initially epidemiology people were involved in this individual. Nobody have or had good information about Saudi Arabia that there is an ongoing outbreak of MERS corona. It seems even those physicians were not listening to the news. It is in all channels. You can just click on CNN, Al Jazeera, the Arabiya, even in Korea. I'm sure in the Korean news they were mentioning about MERS corona, but those healthcare workers initially they failed. Number A, B, C failed in identifying this thing. This is another part. The third part, those healthcare workers, I can translate it here to epidemiology as well. Epidemiologists, they are healthcare workers. They failed to have facts, to ask the individual where you have been. If somebody clicked in his mind that his upper respiratory infection that lingered for a few days or a week plus or 2 weeks, where have you been? Where did you travel to? Which country you were in before you come to Korea? I'm sure somebody would have discovered, and we can avoid this cascade of cases. And of course, this outbreak taught us strongly a new thing about MERS corona, that in epidemiology, we have to think about it, because if we stuck with one fact, like initially we said MERS corona, it's only index case, animal to index case, then index case to secondary case, but there are no tertiary cases. Even initially they say, well, from animal to human, there are no secondary cases. Here you can see even we had tertiary cases in South Korea. So that's what pure one case introduction and give us the cascade. So that's brought about in the literature by somebody who's a working epidemiologist that traced the disease and secondary cases and tertiary cases and came up with conclusion, and he changed the literature worldwide about MERS corona. I'm not focusing on the disease itself, but about the concept of how to handle the illness, and this is not the same. So how FTBEB is integrated into One Health? Of course, now everyone has his input, but just I'm throwing ideas, bits and pieces for us to think about them when we start discussing, like a clinical knowledge of zoonosis, like I said. So epidemiologists, he cannot say, well, I'm concerned with doing facts about certain illnesses in my community. He should be aware, and his mind is open to new events, new symptoms, should a report is coming up and came to his attention. Some training about epidemiology mentioned that potential outbreaks.
he should be able also, his basic knowledge should include potential outbreak. For example, in China, has been going on at 7 and 7, at 7 and 9, sorry, which is an avian swine flu since 2013 until recently. And there were about 200 cases, slightly less than that, with mortality of about 30%. So the world is small now, and it's a small village, and people travel from China to our part of the world easily, and so we have to maintain this information in our mind and knowledge. Basic travel in medicine, as I said, access and knowledge about work dynamics in other official committee, as mentioned previously, belonging to our working group like stakeholders, special interest group, NGOs, concerned ministry. That is, the epidemiologist, the program should be constructed in a way that there is a privilege for the epidemiologist, the field epidemiologist, to get access as quick as he can, not to his ministry. For example, if he belongs to the Ministry of Health, he should have access to Ministry of Agriculture, to some other individuals, organization that they share the same interests with him, and not to go to the field and have the information, come back to the office, just try them, tell his boss, and boss will look, okay, let's see what's happening here, and then will he talk to his minister, and his minister will talk to the Minister of Agriculture, and then down, and then coming to the conclusion. Maybe too late, and the outbreak is becoming grave. So it should be just from the first level communication to start with. Of course, the other levels should know immediately, but there should be communication. A model of learning by doing, and I'm sure you know, most of you know that about field epidemiology, is that not only lecture rooms or discussions, but during the work, actually, practically, to teach, he should be taught properly how to do things. And that's why it should be hierarchy in the system, and not one level doing the job on his own. Mentor senior supervised hierarchy. Do not overwork FTEB, and this is from EuroCDC, because they noticed if the epidemiologist in the field is becoming overworked, his focus, his concentration on his job may not be that accurate. And of course, he should be able to identify cultural sensitivities. In each culture, also he has to understand actually what's going on. I'll give an example. Everybody knows Ebola, this outbreak that took place in Monrovia, Freetown, and the three countries. And one of the failure of the system is that epidemiologists, they failed initially to communicate with people and to talk to them down to their social norms and their habits, and try to change them. And just to tell you, I was flipping the tab, the New England Journal of Medicine, there's an article, it was published in September, recently, 15th, about this issue. And even in the introduction of that article, the authors, they were so mad and angry from the way the Ebola was handled on the scale of, even they mentioned failure of communication between the healthcare workers, epidemiologists, and the people. They have to teach them the habits and to be very culture sensitive individuals to them, so as to gain their trust and to give recommendation to them, so as to help in combating this. And of course, should you, should you collect data, it should be translated to a working plan or recommendations. Publication of outbreak investigation, sharing results with headquarters and other geographic area. Now, even EuroCDC, they justify promoting university degree to make people also happy, not to do only learning by doing in the field alone, and they should have academic titles or degree that you stress upon that within a system, a university or affiliated body, to give them incentives on their personal level, but not to overstress that, because sometimes rigid recommendations in university may hinder or delay the work. Some form of doing that. Now, international and national FTEB interaction is basic, and of course, we cannot overestimate. And this is the hierarchy that I'm sure all of you know that, and thank you. Discussions and points about One Health, how you can integrate or things put together for programs to become a better program.
do you support field epidemiologists or the program there they belong most of the time to Ministry of Health, right? Right, Dr. Adel? They belong to the office in Ministry of Health for communicable disease, etc. Do you support that those individuals, they have some power or they should be empowered to communicate on their own with other agencies? Of course, by doing that, not to exclude his system, he should report immediately his system and himself to other organizations like, for example, the Department of Agriculture, sometimes civil defense, sometimes other stakeholders that they deal with the same problem. Do you support that or just you want to be limited to that? Why?
Thank you, Jamal, for raising the question. I'm just going to, I theoretically agree with you, but let's go to the basics and realities. We have systems collapsing around us. It's not just for animals or for humans, for security, for everything. When you talk about One Health, you talk about high level of coordination and high level of competences at the individual agencies, at the individual institutions, individual ministry, whatever, Ministry of Agriculture, Ministry of Health, ministry. So in order to reach that level of One Health, you want to make sure that all the components are really qualified at the theoretical level, at the competencies level. Then you will move to the One Health concept. And if you look around, I mean, Jordan is the only holding country around you, okay? Systems for humans are collapsing around us. So when you talk about animals also, about agriculture, about other things, I'm not sure how realistic we are being. Maybe in some other parts of the world, maybe. In this area, I'm not sure.
Well, I agree with you, but...
Yeah. I'm raising a question, actually,
Okay,
rather
you
than
are
giving,
for a question. This would not prevent us of trying to do the best we can do, right? Even if we have turmoil around us.
And just to add a comment to that as well, is I think you can also think about it from the other way around. You can think about bottom up. You can think about the human health community workers at the local level and see if they have counterparts on the animal health side who can also coordinate at the point of origin of the emergence of the zoonotic disease. So I think there's multiple levels and tiers that we can think about what makes most sense in a particular country, either top down, bottom up, both, neither. I mean, I think there's lots of different ways to think about it as well.
Let me show you the experience of Egypt in the area of H5N1. For me, as I responsible for H5N1 surveillance, we have a strong cooperation with the veterinary medicine, Ministry of Agriculture through the veterinary services. Once we discover a case positive for H5N1 on suspicion, not on confirmation, we report immediately to the Ministry of Agriculture to move to the source of infection and take specimen. And they do surveillance also on animal side for poultry, and they report to us immediately on a weekly basis the positive foci for us as human health to follow up those people around these positive focus. Also, we make a meeting with veterinary service on a regular basis, monthly, to discover what is new, if MERS-CoV or H5N1 increase or H9N2, and we also in Egypt discover 3 cases of H9N2, not only H5N1 outbreak. So we have a strong cooperation with the veterinary medicine, and on field investigation of a confirmed case, we move in a joint team from the veterinary health and animal health together. We move to the case. to the home to see what is the situation, what is the environment, and they take a specimen and for us to investigate the contacts. And this not only happen on the central level, it is also on the peripheral level, on the district level. They also do the work. And now we are planning to do training to the community health care workers that move from door to door for raising the awareness of the rural areas for the female living in rural areas to improve their awareness about dealing with birds, safe dealing with birds. Not only the training is provided from human health, no, it will be from person from human health and person from the veterinary medicine to say one message by one tongue for the people to apply well, and the message will be now for this point of time about the safe slaughtering, as the slaughtering of the unsafe slaughtering is the most dangerous procedures that they make them infected with H5N1. Thank you.
I was just going to add, I appreciate all of the comments, and I think, certainly there are definitely challenges to this region that are special. However, I would agree with the idea that there is a lot that can be done on a very personal level and sort of the researcher to researcher, health worker to health worker, and that's what I've observed in the region that's been really powerful and crosses many borders and many challenges. You see a lot of cooperation in this region, among Israelis and Palestinians, Jordanians, Egyptians, whomever. People are able in the medical community and in the science fields especially to work past some of those challenges and overcome some of the difficulties that exist in this region and work together because they have shared interests. I mean, none of these things respect borders or, that there's a conflict going on at some ministry doesn't have enough money. So you have to find whatever way you can, to try and implement the concept, the goal, which is really just open communication and building good relationships and trust in whatever way you can. And that's what I think people have done well, but as I've seen in the region.
And I think just to our Egyptian colleagues' comments, I think the work that you've done with H5N1 and the systems and communication between the human health and veterinary services is fantastic. And that type of mechanism can be catapulted to all types of priority zoonotic diseases. It doesn't have to just be for avian influenza. And I think the political goodwill and the funding that's been available for AI has been phenomenal throughout the region and globally. And I think that's where the policy push for ministries to help support other diseases that cross those sectors is crucial. And that's where that high-level support is critical. But as has been already discussed, that low-level communication at the local level is key really for the detection and the response.
Thank you very much. So I will back just to Dr. Jamal's question when he asked how many vets we have in the room, and we had 2. Actually, the 2, I think, or 3 or 4, all of them are not in the region. So, not from the region, I think Stacy and Leah, and we have. So the question, why? Because unfortunately, our FETP programs and our ministries of health does not allow for vet to be a member in FETP. So in the past, we tried. Since we are talking about One Health, I think we can start with simple things where we can apply the concept. So I request really the ministries of health in the region that why we cannot engage vet in our programs. So in the past, we had several attempts to string this concept, One Health, or to work with vet and to work also with the lab at that time. So we still have very opportunistic, events happened in the past. Like in 2007 in Jordan, we trained 2 vets in Jordan FETP. We had 2011 in Yemen. But still, this is exceptions. So really, usually when we go to visit the programs. We need to more, encourage the countries, the ministries of health to change their culture. It's not the concept of epidemiology or outbreak investigation or field applied epidemiology. It's not only for medical doctors. We should work as a team, and I think FTB could be a good opportunity to start applying One Health approach in our region. Thank you.
If you allow me, just let me read for you, just have the screen in front of me, what's published recently in September in the New England Journal of Medicine. Just listen to the words the authors, they say. The Ebola outbreak in West Africa tragically illustrated the shortcomings of the global health system. Dysfunctional governance structures within and among institutions and sectors hindered response efforts. Financial and human resources were slow to arrive and insufficient, as they often are during humanitarian crisis, other things. Surveillance and other information systems were not up to the task. Healthcare personnel risked their lives to provide care, and many died. Local culture was not respected. The mistrust of the health system was rampant. Private industry had little incentives to proactively develop life-saving products, and when it nevertheless did so, regulatory barriers and poor coordination hindered testing and deployment. The list goes on. As the result of Ebola outbreak has had catastrophic health, economic, and social effects on Guinea, Liberia, Sierra Leone, and beyond. And of course, in the second paragraph, he mentioned that we had in the past SARS. We had an example that we can cooperate, we can work in a better way, but we failed to do that in spite of previous outbreaks that we should have learned a lot from them, but we didn't. And honestly, I agree with the authors of the England about this. So,
I think just one comment about different mechanisms to be able to engage the veterinary sector in an FETP program. There are many examples. In sub-Saharan Africa, the Nigeria FETP program has an excellent One Health coordination effort. So the veterinarians are paired with the physicians to do field work. Those courses are separate, but then they're pulled together for field work. In Kenya, there is the Zoonotic Disease Unit, which is actually a collaborative effort between the Ministry of Health and the Ministry of Agriculture, and they signed an official memorandum of understanding. And their FETP residents actually do their fellowship program within the ZDU, and they will then go out in the field and respond together. In Southeast Asia, there are many great examples of One Health programs in Thailand, in Vietnam, where the veterinarians and the medical clinicians are trained together in their courses, their didactic training, and then in the field. So I think that it's not a one-size-fits-all approach. Can be tailored to the region, to the country, to the needs and the diseases that are of highest risk, not only to the animal population, but to the human population. So I think, particularly in this region, I think that the idea is to be flexible and how best to include the veterinarians in this type of training and response.
any comment, anything, just before? All the way, the gentleman in the back.
Working for EMPHNET, and one of the things inspired me to join is to convince EMPHNET to do FAT program in Somalia. And it's discussions are happening. If I come back to the zoonosis issues and one concept, one health concept, let me share with you an experience we gained from Horn of Africa. We developed a joint partnership between all the countries in East Africa, especially under IGAT, to make a secretariat to look at HIV, ministerial level. And that has helped us to make a joint coordination activity on prevention and control of HIV/AIDS, especially through cross-border. People are moving a lot. And then we had another problem on tuberculosis. And then tuberculosis has reached to a ministerial level to control the cross-border issues of TB treatment. People are moving. Today he is in Kenya, tomorrow they are in Somalia, next day he is in Ethiopia. So one health concept can be strengthened and can be established through the joint cooperation of the countries in the same region. This is what we have learned, and it's very important. For example, Somalia it's a good opportunity to establish these issues. We got a health infrastructure completely collapsed. The veterinary services completely collapsed. Yet we are one of the largest exporters of livestock to Middle East. Anything can happen. What will happen? It will be a disastrous effect. If we export animals which has not been controlled, not been treated, not have been under a strong surveillance system, and yet exported to, we are getting daily flights to Middle East, to Dubai, to Doha, to Istanbul for carrying live animals. So all these problems can be averted simply by establishing this FATP system incorporated with veterinary skills. If the Ministry of Health of Jordan did not allow, but we can do it in Somalia, and this can help EMPHNET to show a model that can be an example. Thank you.
Thank you.
Thank you for your comment. I think one of the really interesting perspectives is looking at, as Elizabeth mentioned, trade implications when you think about livestock, food safety issues, and even taking it disease by disease, sometimes doing a cost-benefit analysis of intervention in the veterinary sector saves a lot more money for the health sector in terms of prevention of treatment of human patients or of money lost from animal trade and banning of meat and even just the rumors that can be associated at times with potential disease outbreaks. So being creative with how to promote One Health interventions and networks, both at the local, regional, and central levels, I think is very important. So thank you for your comment.
It is. Now, do we have last comment, because it's now 17:05. So we are 5 minutes above schedule, right? Because you told us to be sharp about time. So, so I have this 1 minute. Now we have minus 5 minutes now. Any comment, final comment? Okay, thank you all.
We need to make just one announcement. I want to repeat the announcement that was said earlier. We received an invitation to all of you from Aqaba Special Economic Zone Authority. They are inviting us to go on a boat trip tomorrow. Buses will be leaving at 5:30.